fortunate today to have Dr. Denise Houston as our inaugural presenter. And just a quick bio on Denise. She's a nutritional epidemiologist and registered dietitian in the Department of Internal Medicine sections of gerontology and geriatric medicine at Wake Forest. Undergraduate degrees from the University of Georgia, and received her PhD in nutrition with a minor in epidemiology from the University of North Carolina at Chapel Hill. Her research interests are varied, include the role of micronutrient status, dietary patterns and weight history on physical function in older adults. She received a K Award in 2008 from the NIA, investigating the association of vitamin D status and related gene polymorphisms on muscle strength and physical function in older adults. And she's the co-investigator on several other grants looking at weight loss, obesity, physical function in aging. She is the immediate past chair of the Aging and Chronic Disease Research Special Interest Section for the American Society of Nutrition. Has more than 50 research publications and importantly 2 R01s in the pipeline. So thank you very much for joining us.
Thank you.
Welcome.
Thank you. Good afternoon. I'm going to talk about vitamin D today, and I think that's a topic that may not get much coverage here, even though I know that if we just go outside, you could probably get some vitamin D today. So I'm going to talk about vitamin D, but not talking about the traditional bone health and osteoporosis. I'll be talking about vitamin D and physical function. So this is a pretty simplistic overview of vitamin D metabolism. We get most of our vitamin D when our skin is exposed to sunlight, but we can also get it from some food sources. In the liver, vitamin D is converted to 25-hydroxyvitamin D, and this is what we use to determine someone's vitamin D status. In the kidney, it's further hydroxylated to 125-dihydroxyvitamin D, and this is the active or hormonal form. And traditionally, we've thought of vitamin D as playing a role in both bone formation and resorption, as well as in helping absorb calcium through the intestines. So those are kind of the traditional roles of vitamin D. About 15 years ago, the whole area of vitamin D research exploded. There we go. And now there are at least 10 extrarenal organs that have been discovered to possess 25-hydroxyvitamin D, 1-alpha hydroxylase, and can convert the 25-hydroxyvitamin D to 125-hydroxyvitamin D. And that includes the brain, colon, pancreas, and prostate. And at least 37 cell types have been discovered that have vitamin D receptors, or VDRs, and combine the 125-hydroxyvitamin D. And one of those is the skeletal muscle. At least I believe it's the skeletal muscle. There is some debate as to whether or not there are VDRs in skeletal muscle. And because of all of this new research in vitamin D, there has been a lot of conjecture about how vitamin D may improve a lot of different health outcomes. Potential causes of deficiency include lack of sun, whether it's through lack of exposure, latitude, winter season, but also use of sunscreen, and then individuals who have high melanin content. Medications and supplements, there are certain ones that can impair absorption, as well as some malabsorptive conditions that can impair vitamin D status. And then you have things like liver failure and kidney failure can impair vitamin D status, as well as obesity. So it's thought that in obese people, the vitamin D is sequestered in fat tissue, and that's why their vitamin D levels are low. And in general, we just have a very low dietary intake of vitamin D. On this side, you see this list of consequences that keeps growing, and I will say that this is potential consequences. Most of our research to date has been in observational studies, and so we observe associations between vitamin D levels and these outcomes, but other than bone health, we really haven't tested them in trials. As far as aging-related consequences, things like cognitive impairment and depression are things that are now becoming observed in observational studies. Things like coronary heart disease, high blood pressure, type 2 diabetes. And then, what I'm going to focus on really is this muscle weakness or muscle strength. So there is this long list of different outcomes that could be related to vitamin D, but I think until we have more clinical trial data on some of these outcomes, we may need to hold back and maybe not be quite so optimistic about vitamin D being the next wonder drug. There's also quite a big controversy of what we want to call sufficient vitamin D status. Even though the 2010 IOM report came out, there's still controversy ongoing as to whether the cut point that they described is actually the right cut point. It's pretty consistent that people will accept either less than 10 nanograms per milliliter or 25 nanomoles per liter as clinical deficiency for vitamin D. The controversy is really where do we call insufficient? The IOM has said it's 20 nanograms per milliliter. Some people suggest it's 30, some people think it should be as high as 40. And there is some data now suggesting that probably we shouldn't have levels that go above 60. There has been a few observational studies showing that people who have really high vitamin D levels have increased risk of mortality. But really it's this area in here, what do we want to call insufficient? The IOM cut point is based on bone health alone because that's where the clinical trial data is to date. But whether or not that is sufficient for other outcomes, we don't know. When we look at the prevalence of vitamin D insufficiency, this is data from the NHANES 2001 through 2006. And if you look at adults, pretty much it's consistent across all adults that there is a pretty widespread problem of vitamin D deficiency. And this is defined as less than 20 nanograms per milliliter. A little higher in females than in males. If you use the less than 30 nanograms per milliliter cut point, this would be 2/3 instead of 1/3. So where the cut point is really kind of makes a big difference as to how you describe the problem. Is it, a small problem, although I think 1/3 is still a lot of the people, or is it, pretty much nationwide we have this issue of vitamin D insufficiency. So why are older adults at greater risk for vitamin D insufficiency? A lot of older adults just don't get exposure to sunlight, so they stay indoors, or if they are outdoors, they use sunscreen or wear more protective clothing. As we age, we have a decreased capacity of the skin to produce vitamin D. There's decreased 7-dehydrocholesterol in the skin. And this is a study that was conducted several years ago showing both young adults and older adults and the amount of vitamin D production from the same amount of sun exposure. And you can see that the older adults produce only about 1/4 of the amount of vitamin D compared to the younger adults. There's also inadequate dietary intake, and a lot of this is because there are just very few foods that naturally contain vitamin D. Examples would be the fatty fish like salmon, tuna, and sardines, which, at least in this country, are not the fish that we typically consume. This is also data from NHANES 2005-2006. The yellow bars here show the intake from diet alone. The kind of purpley bars are intake from supplements, and then the light blue bars are where we are deficient from the recommended dietary allowances. So for older adults, 71 and older, they're only consuming about half the RDA for vitamin D. So we do a lot of work on physical function at Wake Forest with the Pepper Center, and we know that limitations in physical function strongly predict future disability and result in dependency and institutionalization. We also know that they also contribute to greater healthcare costs and utilization of healthcare services and poor health outcomes and mortality. And so identifying factors that postpone or prevent limitations in physical function is a priority, which is one of the things that started us looking at vitamin D when I first came to Wake Forest in 2004. So we wanted to kind of see what the potential roles were for vitamin D on muscle strength and physical function. This was an area of research that was just starting at that time. Now it seems like everybody's doing it. But when we first got into this, very few people had started looking at vitamin D and physical function. So there are several pathways by which vitamin D may affect physical function. Osteomalacia, which is the softening of bones, is seen in people who have overt clinical vitamin D deficiency. This would be people with 25-hydroxyvitamin D levels less than 10 nanograms per milliliter. And the symptoms include weak or soft bones resulting in fractures, bone pain, proximal muscle weakness, and gait impairment. So this kind of lends you to believe that there would also be some implication on function. There's also been some evidence from muscle morphology studies where muscle biopsies from vitamin D deficient individuals show that type 2 muscle fiber, there's reduced type 2 muscle fibers. And these are thought to be the first fibers recruited when trying to prevent a fall, which might be why there's been a number of studies that have looked at vitamin D and falls and seen a protective influence of vitamin D. This was one of the early studies looking at vitamin D supplementation, and it actually looked at the muscle fiber composition. And in these older stroke patients, the supplementation resulted in an increase in relative number and size of type 2 muscle fibers, as well as a reduction in falls. There's also molecular mechanisms by way vitamin D can impact muscle function and physical function through genomic pathways with the binding of 1,25-dihydroxy-D to the nuclear VDR. This would impact protein synthesis and regulate cell proliferation. Non-genomic pathways binding 1,25-dihydroxy-D to membrane-bound VDRs, and this would result in activation of protein kinase C and the release of calcium into the cytosol for muscle contraction. Other potential effects, well, I showed you that slide earlier with vitamin D and all the potential outcomes. Vitamin D is associated with many of the same chronic conditions that are directly related to impairments in physical function: osteoporosis, knee and hip osteoarthritis, diabetes, hypertension, and cardiovascular disease. And then there's inflammation. There has been some suggestion that vitamin D might play a role in the inflammatory response, and people with low vitamin D levels might have higher levels of IL-6, TNF-alpha, and CRP. And we know from other studies that inflammation has a role in physical function, both with prevalent physical function as well as decline in physical function. So this may be one other pathway by which vitamin D plays a role in physical function. So about, I think, 5 or 6 years ago, we set out to look in the Health ABC cohort initially to determine whether levels sufficient to prevent vitamin D deficiency in older adults were adequate for optimal functional health. And so primarily I'm going to show data today from 2 different cohorts: the Health ABC study, which is a prospective cohort study investigating the association between body composition, weight-related health conditions, and incident functional limitations in initially well-functioning community-dwelling older adults. We have about 27 or 2,800 people who we have vitamin D levels measured. The original cohort was just over 3,000 people. And these were aged 70 to 79 years at baseline, which was in 1997 to 1998. And they're still going back and seeing these individuals on an annual basis. I'll be showing data out to about 6 years of follow-up with the vitamin D. And then we also have data from the CHS All-Stars study. So CHS is the cardiovascular health study. And for the All-Stars, what they did is went back to look at the survivors of the CHS study to determine the likelihood of maintaining function later in life. And for this analysis, we only included those people who had a clinic visit where blood was drawn in order to get the vitamin D levels. So we have 988 people who we have blood levels in the CHS All-Stars, and their age was 79 to 100 years. As far as physical function measures that we're looking at, objective physical performance, a physical performance battery, which can range from anywhere from a 3 to 6 meter walk, repeated chair stands, and standing balance tasks. In Health ABC, because they were well functioning at baseline, the standing balance tasks are expanded to 30 seconds rather than the traditional 10 seconds in the SPPB. And also they do a 6 meter walk instead of the 3 or 4 meter walk, and they do a narrow walk test of balance where they have to walk between 2 strips of tape that are 20 centimeters apart. And so the scoring is a little bit different, but it's also primarily to get away from the ceiling effect that you would see if you just use the traditional SPPB. We also have gait speed over 4, 6, 20, and 400 meters. Some measures of muscle strength, including grip and knee extensor strength. And then also some measures of subjective physical function. So this would be any difficulty walking a quarter mile or up a flight of stairs would be mobility limitation. For disability, this would be severe difficulty or unable to walk a quarter mile or up a flight of stairs. So when we first looked, mostly cross-sectional studies had been done. And in general, the cross-sectional studies do show that insufficient 25-hydroxy-vitamin D is associated with low muscle strength and poor physical function in community-dwelling older adults. This was one of the first large studies to come out. This is from NHANES 3 data. So this was data that was collected between 1988 and 1994. Looking at vitamin D levels here, this is in nanomoles per liter. You can convert it to nanograms right here. And this was looking at only the older adults in NHANES. So these were all people who were at least 60 years of age. and looking at the time to walk an 8-foot walk and the time to do the chair stands. And what this graph shows is that as the vitamin D levels go up, you see the times to complete the 8-foot walk and the chair stands decrease, so that people who have lower vitamin D levels have poorer function here. So we looked at this in Health ABC cross-sectionally, and this is their physical performance battery score, which is on a different scale. It's 0 to 4. We categorize people as having vitamin D levels less than 20, 20 to 30, and 30 or above. And what we do see here is a pretty, I guess, a linear association between vitamin D levels and the physical performance battery. When we look at 400-meter walk, we see the same thing, where we kind of have this linear association between vitamin D levels and the time to complete the 400-meter walk, where both people who are less than 20 and in the 20 to 30 group have significantly slower times on the 400-meter walk. In the CHS study, they use the traditional SPPB score, so this is on the 0 to 12 scale. And again, using the same cut points of less than 20, 20 to 30, or 30 and above, we see this linear association between vitamin D levels and their short physical performance battery score. Looking at muscle strength, looking at knee strength, we actually didn't see anything cross-sectionally with vitamin D levels and knee extensor strength in Health ABC, and this was adjusted for leg lean mass. But we do see an association between vitamin D levels and grip strength, and we had seen this earlier in the Inchianti study, but nothing with the knee strength here. And this is the CHS data, and again, although this does look like there's some indication of an association, there's no significant association between vitamin D levels and knee extensor strength in these older adults, but there is an association with grip strength. So one of the things we set out to do was to determine whether there's a threshold for physical function and if this threshold differs from that for osteoporosis and bone health. There are a lot of people in the vitamin D research community that think that the optimal vitamin D levels should be at least 30 to 32 nanograms per milliliter rather than 20, and have been suggested for different various outcomes such as heart disease, cancer. In NHANES 3, most of the improvement in walk speed and sit-to-stand time occurred in individuals with 25-hydroxy-D levels between 9 and 16 nanograms per milliliter. So that would be below the 20 cut point that IOM has and not quite as high as this 30 to 32. In the longitudinal aging study Amsterdam, they found a threshold of 20 nanograms again for optimal physical function. However, in the Rancho Bernardo study, physical performance continued to increase up to levels of 32 nanograms. So kind of seeing that there is somewhere between this 20 and 30 and where exactly might be the optimal threshold for vitamin D levels. So we did this cross-sectionally in Health ABC, and what we did is we fit two piecewise models to determine a cut point. So the cut point here is determined by the statistical model, and along the bottom, this axis is in nanomoles, so 1 nanomole is 0.4 nanograms per milliliter. And here's the Health ABC physical performance battery score, so a higher score is better. And what you see is below this cut point here that the model determined, there is an increase in their physical performance as the vitamin D levels go up. And this increase is significant. However, after the cut point, the line flattens and there's no longer a significant increase in their physical performance with increasing vitamin D levels. And the cut point determined by the model was 30 nanograms per milliliter. When we looked at 400-meter gait speed, again, we've got the 25 hydroxy vitamin D levels here and meters per second here. And we see below this cut point line that there's an increase in gait speed with increasing vitamin D levels, and it's significant. However, after you reach this cut point, there is no significant association between higher vitamin D levels and their gait speed. Now, we did this for all the physical performance measures we had in Health ABC. The regular SPPB score, the 0 to 12 score, the physical performance, the Health ABC physical performance battery score, 20-meter gait speed, 400-meter gait speed, the knee extensor strength, and grip strength. And pretty much what we found is a threshold, at least for the physical performance measures, around 30 nanograms per milliliter, slightly lower for the strength measures, around 22 to 26. And the slope below the threshold was significant for all but knee extensor strength. And then the slope after the threshold was not significant, suggesting that up to a certain point, vitamin D levels are important, but after that, there may not be an advantage to going higher. We also looked at this by gender and by race and by season and by BMI group, so obese versus non-obese, and found pretty much that these cut points were similar across all of the different groups. And that was something we were interested in to see, did the cut points differ by black, white, ethnicity, race? Did they differ if you were obese versus non-obese? And we didn't find any differences in the cut points across the different groups. So this would suggest that there is a threshold for 25-hydroxyvitamin D in physical performance at approximately 30 nanograms per milliliter. And it might be slightly lower for strength associations. So moving then on to longitudinal studies, there have been fewer of these, and the results tend to be mixed, showing either no effect of vitamin D on changes in physical performance or greater declines in physical performance in those who have lower vitamin D levels. So again, this is data from the Longitudinal Aging Study Amsterdam, showing the effect of vitamin D levels and 3-year decline in physical performance. And here they are using the less than 10 nanogram category, 10 to 20, 20 to 30, and 30 or above. And in both of these categories, less than 20, you see that the odds of declining in physical performance was increased compared to those who have vitamin D levels above 30. And here they didn't really find a significant association between those in kind of in the middle category. So we looked at this in Health ABC over 4 years. And so the blue line here are those individuals who have vitamin D levels less than 20. The pinkish red line is the 20 to 30 group, and the yellow line is the 30 and over group. And what you see here is consistent with our baseline analysis. The people who have higher vitamin D levels have higher performance at baseline. And over time, you can see that these lines are parallel. So basically, they're all declining, but there is no association with the rate of decline by their vitamin D status. So they're all declining at a similar rate. And this is for physical performance. And then here is the data for the 400-meter walk speed. Again, you have the lowest vitamin D group here, the middle group, and those who have levels above 30. And you can see that these lines basically parallel each other. So this would indicate that maybe vitamin D is not really associated with declines in physical performance. And so why is this? Why do we see different results in different studies? And some of it's differences in study population. Some of the studies have used people who are already disabled, and they did not find an effect. Some of them have a much lower vitamin D level status, like the LASA study. Here, their vitamin D levels tend to be in the 10 to 20 nanogram range. Study out of the study of osteoporotic fractures that has also looked at this, their vitamin D levels are up in the 30 to 40 range. So you've got different vitamin D levels, you've got differences in their study population. And then also the cut point used to determine their vitamin D status. Some of them aren't used, if they're all using different cut points, it'd be difficult to tell what the association might be. And then also looking at change in physical performance. If you're just using pre-post and just looking at change, you might not see the same results as someone who is looking at it kind of the way we did it, where we're plotting it. You're still seeing everyone declines, but it's not changing the rate by vitamin D status. So this led us to ask whether or not vitamin D would alter the disability trajectory. And so we postulated that you have two people, one who has insufficient vitamin D and one who has optimal vitamin D levels. And so they start off where the people who have optimal vitamin D levels have higher performance than those with insufficient levels. But over time, because they're declining at the same rate, they would still cross this disability threshold if you're insufficient at a faster than those people who have optimal levels. So maybe still this would have some effect on disability. So this is data from Health ABC looking at incident mobility limitations over a 6-year period. And what we found was that individuals who had less than 20 nanograms per milliliter or 20 to 30 for their vitamin D status, they had significantly higher risk of developing mobility limitations over that 6-year period. It's about a 30% increased risk. When we look at mobility disability, this is where they either have severe difficulty or are unable to do the task. Again, we see that those people in the less than 20 nanograms per milliliter had significantly higher risk of developing the severe mobility disability over that 6-year time period. We looked at this in the CHS study also, and here they only have follow-up for 3 years, and their follow-up was done by phone, which is why we don't have any follow-up measures of the objective physical performance in CHS. And again, we found that those individuals who had vitamin D levels less than 20 were at significantly greater risk of developing mobility limitation over that 3 years of follow-up. So what about falls? You think about function, you think about muscle strength. Well, then the link between vitamin D and falls has been primarily through the idea that it plays a role in muscle strength. So this is data again from the LASA study showing that individuals who have very low, this would be clinically deficient vitamin D levels, were about 2-fold higher risk of having a recurrent fall or at least 2 falls over the following year than individuals who had higher vitamin D levels. We looked at this in Health ABC, and as you can see here, again, we use the same categories as the LASA, where we have this less than 10 group. And there is about a double the amount of recurrent falls in those who have vitamin D levels less than 10 compared to 30 or greater. But you can see here, we have very few participants down in this less than 10 group. Only 4% of our Health ABC participants were clinically deficient in vitamin D. And so what did we find? This is looking at recurrent falls, so they had to have at least 2 falls over the following year. The first model is just adjusted for age, gender, race, site, education, and season of year. And you can see there seems to be somewhat of an association with this very low, less than 10 nanogram per milliliter vitamin D group. When we further adjust it for things like smoking, physical activity, BMI, kidney function, medication use, and history of falls, you see that this is reduced. And here in general, there's no significant association between vitamin D levels and falls. And so that led us to wonder, well, what's different about Health ABC? Well, one, these people were recruited to be well-functioning, so maybe they're just not as functionally worse off as some of the other cohorts that have looked at this. But we also noticed that when we looked at vitamin D levels across different chronic conditions, the people who had been diagnosed with osteoporosis or were taking osteoporosis medications had much higher levels of vitamin D. Now, they probably have higher levels of vitamin D because they've been told by their physician to take calcium and vitamin D to prevent a fracture. And how do you fracture? Well, you fall in order to get the fracture in most cases. So we wanted to look in those people who had who didn't report osteoporosis or osteoporosis medications to see if there was a difference in this association if we excluded those people who may be at higher risk for falls but have higher vitamin D levels because they were taking supplements that had been prescribed to them by their physicians. And this is what we see now, excluding those people who either report osteoporosis or osteoporosis medications. Here we see that in this first model, which is adjusted for age, gender, race, education, and season of year, that the individuals with overtly clinical vitamin D deficiency did have a greater risk of falls over that 1-year follow-up period, as did the people in the 10 to 20. When we adjust for the confounders of physical activity, BMI, other conditions, medication use, and history of falls, this is attenuated somewhat, so it's no longer significant, but there is still a trend there. So this would suggest that sometimes when we see an association, we need to make sure that we can't rule it out by some other explanation. So in the whole cohort, including those people with osteoporosis, meant that we were bumping up some of the people who are at greatest risk for falls because they were also taking their supplements, so we may not see the association that was truly there. So what about vitamin D supplementation and functional decline in falls? There have been some studies that found improvements in muscle strength and physical performance with vitamin D supplementation. One of the biggest studies that looked at this was the Women's Health Initiative. And their trial of calcium and vitamin D supplementation did not show a benefit in preventing decline in physical function in older women over 7 years. But I'll point out that their vitamin D dose was 400 IUs per day. And this has been something that, not just for physical performance, but some of the other health outcomes that they looked at in relation to vitamin D, it may not have been a high enough dose. Another limitation of the Women's Health Initiative study is that although they were in the calcium vitamin D arm, people were allowed to continue taking whatever supplements they were on during the study. So if they came in taking calcium, if they came in taking multivitamins that had D, they were allowed to continue on those supplements and then had these added to them. So this is a recent meta-analysis looking at vitamin D supplementation studies and different measures of physical performance. And what we see here is that there seems to be a protective effect of vitamin D supplementation on balance or sway in several studies. The timed up and go test, you have a shorter time on the timed up and go test if you're randomized to the vitamin D supplementation group. But kind of consistent with our Health ABC and CHS data, they didn't find any association between vitamin D supplementation and lower extremity muscle strength. When we look at vitamin D supplementation in falls, there's been numerous meta-analysis on this. Heike, Bischoff, Ferrari has done several meta-analysis, and this is the most recent one. And this splits people up into whether or not the intervention study used a higher dose of vitamin D or a lower dose. And what this shows, it's only at this higher dose of vitamin D that you see a protective effect of vitamin D on falls, that you don't see this protective effect using the lower doses. So where do we go from here? One of the things that I think we need to do is start doing interventions of these health outcomes beyond bone, and especially in my interest in physical function, is to look at an intervention designed to see whether or not treating vitamin D insufficiency will improve precursors of disability, so this would be your physical performance and muscle strength, and also whether or not you can see some recovery from limitations in disability with vitamin D supplementation. Additionally, understanding the underlying mechanisms by which vitamin D improves physical performance. There have been 2 previous studies that did muscle biopsies in vitamin D supplementation trials. They were in the late 80s, early 90s, and they do show that vitamin D supplementation increases the type 2 muscle fiber. And also, from our pilot data, we observed that too. And also saw a decrease in denervated myofibers, suggesting that vitamin D does play a role in the muscle function. But we really need to kind of have some idea of what's going on in the muscle and why vitamin D might have this protective effect on physical function. And I'd like to acknowledge my collaborators at Wake Forest, Steve Krzyzewski. Janet Tews is my biostatistician who made all those nice piecewise regression models for me. Gary Schwartz, he mainly does vitamin D cancer research, but he is one of the first to really look at vitamin D. Osvaldo Nabano is our muscle physiologist and has helped us with some of our pilot work that we're hoping to expand into a clinical trial if we get funding from NIA. The National Institute on Aging, Tammy Harris oversees the Health ABC study. We had our vitamin D levels measured at the University of Georgia by Marianne Johnson and Dorothy Hausman. And then the Health ABC and CHS study both have investigators at Pittsburgh, Jane Cawley and Ann Newman, Doug Bauer at UCSF, and Alice Arnold at UW. And then acknowledge the funding sources for these different cohort studies, as well as our Pepper Center and my KO1. Thank you.
Thanks, Denise. Any questions?
So the question is, how much variability is there in vitamin D status and how it might affect your associations that you're seeing? So there is a seasonal effect with vitamin D. So at least in the Northern Hemisphere, we expect to see vitamin D levels that are higher in the summer and fall months than in the winter and spring months. And all the data I showed here, they were adjusted for season, so we take that into account. The difference between seasons, there's a study out of the CHS cohort that looked at that really nicely, and it's about a 10 nanogram per milliliter difference between someone who might be measured in the summer versus the winter. So there is a, depending on the season, there is a big difference in your vitamin D level. In all these cohort studies, we measure people at the same time of the year each time. So there is some fluctuation. So what you would expect is someone whose vitamin D levels are deficient in the summer is much worse off than someone whose vitamin D levels are deficient in the winter. But we try to take into account in our modeling, by including the season and looking at season interaction, whether or not, try to take all that into account. So the question is about whether or not there are VDRs in the muscle and whether or not the effect is local or systemic. So there's some debate. I know DeLuca's group came back and said again that there are no VDRs in skeletal muscle, but there have been 3 other groups that have shown VDRs in the skeletal muscle. So I think there probably needs to be more studies to determine that, and if we get funded, we'll look to see if there are VDRs in our skeletal muscle biopsies. And I would think it would have both effects. So I think you would see both a systemic effect as well as a local effect. So I don't know that we really know a lot about the mechanism of how vitamin D works in the muscle, which is probably kind of an area that needs to have more work done. Yeah, so the whole idea with vitamin D deficiency and you think sunny climates should have better vitamin D levels. I know there's studies out of Hawaii, there's studies out of Florida, and they all show that's really not the case. I mean, even in Health ABC, it has 2 sites. One is Pittsburgh and one is Memphis. Well, Memphis is definitely at a lower latitude than Pittsburgh, so you would think their vitamin D levels would be higher, but they're not because the summers are so hot, everybody stays indoors and stays in the air conditioning. So just because you're in a sunny climate doesn't mean that you're necessarily getting exposure to sunlight. And if you are, you might be using sunscreen, which is going to block the vitamin D production too. So, yeah. So the question here is, we have all this observational data, but we really don't necessarily know whether intervening on someone who has low vitamin D levels is going to have any benefit on whatever outcome it is we're interested in. And I think that's why the IOM report came out how it did. I think a lot of people were very disappointed in the IOM report because the vitamin D levels they recommended were 20, and that's based actually on what the nutrient intake should be. So that's based on either 600 IUs a day or 800 IUs a day. And people were thinking that it was going to be 2,000 IUs a day was going to be the new recommended dietary allowance. And that was all really driven by these observational studies. And try as we might to adjust for confounding factors, we can't measure everything well, we can't control for everything. And that's why it's really important that these trials happen. There is the VITAL study going on out of Brigham's Women's Center where they're randomizing people to vitamin D and fish oil, and I think it's 20,000 people, and main outcomes are heart disease and diabetes, but they also have a lot of ancillary studies. I know cognition is one of the things they're looking at. So that's going to be a big study that will tell us a lot about whether or not we give people a supplement, do we see an effect on these outcomes other than what we've seen with the bone trials. That study still has a lot of problems. It's basically a repeat of the Women's Health Initiative study where everybody that wants to participate is participating. It's not based on the individual's initial vitamin D levels. So we're going to be throwing supplements at people who may already have plenty of vitamin D, and we may dilute any effect that we could see because we're not only looking at people who have low vitamin D levels. So I think that's where it really is important, to do these trials to make sure that vitamin D is just not some marker of health, and that there is something going on, and what are the mechanisms? I mean, even with muscle, there's some indication it might be through the VDRs and the type 2 muscle fibers, but there's 2-3 studies out there that have really looked at that. So we do really need to do the clinical trials to determine, what is this based on? What is the underlying physiology? And, do we really need to supplement people? I think the IOM kind of was conservative, but I kind of agree that there is no data really to say that we should be, supplementing with 2,000, 4,000 IUs a day at this point. Yeah, so the question is whether or not, we should be doing more either to the food supply or supplementation as far as vitamin D, and then what the risk may be if we're supplementing everyone with vitamin D, given that it eventually is a hormone, and there might be some risk for the higher vitamin D levels. So just 2 weeks ago, the FDA approved the addition of vitamin D fortification to basically breads, grain products, baked goods. In the past, it's only been vitamin D fortified milk, and that's been like the primary source of vitamin D in the diet. So now we're going to be adding vitamin D to breads, and that'll have about the same amount of vitamin D as a glass of milk. So we're kind of already moving down that step. I had no idea that it was even under a review until I got the email from someone, did you hear this? And so I think that's interesting that we're already trying to put it in more foods. The studies that have looked at mortality in vitamin D, there are, I think, 2 out now. Both of them have been in basically cardiovascular risk populations, where these are people who are coming, these are both in Europe, where they have nice electronic medical records and they can follow everybody. And it seems like it's the cardiovascular mortality that is driving a lot of the association. But typically what they've shown is, probably somewhere over 60 is maybe potentially harmful to have your blood levels that high. We did try to look at, we did a paper on mortality and vitamin D in Health ABC, and we tried to separate the people in the above 30 group. We don't have a lot of people that are above 50, so we had to use like above 40, and we didn't actually see any difference between those that were between 30 and 40 and 40 and above. So again, it's getting at, well, who is the population? As far as the vitamin D being a hormone, the 125 dihydroxy vitamin D is very tightly controlled. So that's why we don't measure it as a marker. So there is some suggestion that the 25 hydroxy vitamin D might have other effects beyond just being converted to 125, but I think we just really don't know enough, which is why I think I'm one of those people on the conservative end that says, well, wait a minute, we really need to do the trials before we start, telling everybody to increase their vitamin D through supplements and that kind of thing. So the question was about the the supplement industry not being regulated, and how can you trust your supplement actually containing what it says on the label? Well, you really can't. There are, and I'm blanking on, there is a certification that you can get. A lot of vitamins will have a USP, so basically it conforms to certain manufacturing practices, and it's supposed to be within a certain range of the amount on the label. There's a consumer reports group that actually will put out annually a list of those vitamins that they've tested that meet within a certain range. And when we've done some of our kind of pilot open label studies, we've gone to see, okay, what do they think is a good supplement if we want to try a vitamin D trial, but pilot open label, small study, and picked one off of their list. But in general, we really don't know what we're getting in those supplements. And we also don't know about the combination, with all the other vitamins and minerals that are in there. What are we absorbing, even if it contains what it is on the label?
The vitamin D that's added to milk, do we know if that's regulated or if that comes from the same companies?
Well, it's vitamin D3, and there was a study, probably in the early 1990s, showing the variability of the vitamin D content of milk, anywhere from 40% of what it's supposed to be up to 200%. So. Yeah, even in your fortified milk, there's going to be a lot of variability in the vitamin D content. And I'm sure the same thing is going to happen with the grains product. This is through anything that would need yeast. There's a vitamin D yeast that they're going to be using that has gotten approval to be used in grain products. Right. So the question is about the relationship between vitamin D and falls. Is it working through physical function? And the idea is that to some degree, yes, that people who have more muscle strength would be able to capture themselves from that fall better than someone who doesn't. So it's thought that the physical performance, physical function of the person would then relate to whether or not they fall. So what we've tried to do in a couple of our analysis is take into account their physical performance and see if there's still a relationship. In the Inchianti study where we did that, we still saw an association, but I think you would expect that the pathway between vitamin D and falls would somewhat be at least through physical. It also may be through cognition and just reaction time too, because there are VDR receptors in the brain, so that may be part of it.
So did you, I may have got this wrong, but when you were doing knee strength, whatever that's called, were you adjusting for quad mass? Is that what you said?
So in the Health ABC study, we have DEXAs on everybody. So we have their
Yeah.
total lean mass as well as like leg lean mass. So we did adjust the knee strength for lean mass in Health ABC. We couldn't do that for CHS. The problem is people who are bigger are stronger, but obesity is associated with vitamin D deficiency. So it was some way of trying to adjust for body size. So a bigger person is going to have higher strength, but then again, most likely lower vitamin D levels.
But, I mean, isn't that kind of like over-adjusting? I mean, in other words, you know, then it's just whether that particular muscle works better. Not, I mean, in other words, your mechanisms of where vitamin
Right.
D might affect muscle might include something that increases mass. I mean, as opposed to adjusting for body weight or some
Right.
other issue like that.
Yeah, yeah, I can see that too. You know, the difficulty is most of our participants in our studies, you know, an older population, we have a lot of obesity. And so how do you get around the idea that the obese individuals in the study populations are stronger, whereas
Just by weight.
you can do it by weight.
Pardon me?
You can do it, and you could also do it by BMI. They're very correlated. You know, we did it by BMI, we did it by lean mass, and we chose to do it by present by lean mass. We have in the CHS, we also looked at it by using a residual of the vitamin D and BMI to try to get around the whole idea that people who have a higher BMI have lower vitamin D levels.
But then the question is, does vitamin D affect muscle quality then, as opposed to?
Yeah,
strength,
yeah,
right?
probably is getting more at muscle quality and the work of the muscle rather than.
Any last questions? If not,
Thanks again.
Thank
Denise.
you.
That was excellent.